meeting and Gore for inviting me. So I'll just present this time a case of successful intervention using a Viapan endoprosthesis for a failing AVF with recurrent stenosis. These are my disclosures. Our patient is a 70-year-old gentleman. He is known to have diabetes for 25 years, hypertension and end-stage renal disease. So he had a recently created left arm brachiocephalic arterial venous fistula. So 2 months later, he was having an issues with his fistula, with poor flow and immaturation. So he was referred to us, and we did the fistulogram. So again, tiny inner part of the micropuncture sheath into the brachial artery, and we did an arterial fistulogram so that you have an idea about the whole circuit. And you can see the tortuosity in areas of kinking and stenosis within the cephalic vein segment. So we established, and you can see some collaterals as well, and there was no issues with the central vein. So we established a venous access antegrade, and we started with the angioplasty with the 6 millimeter and 5 millimeter. And this is the result, which is an acceptable result for us. So the patient went for dialysis, and he had a good dialysis after this. And again, in 3 months, he came back again with this time again poor thrill and almost non-functioning fistula. So we did the fistulogram access, and again you can see almost no flow into the segment with a lesion in the juxtaanostomatic segment as well. So we're able to cross this area, and we started angioplasty, and you can see the waist and the cephalic arch region. So we did multiple dilatations with balloon dilatations, and then this is the fistulogram, which showed better flow with a lesion of mild stenosis in the juxtaanostomatic segment, and the central veins were good. So thrill was okay, and patient went for dialysis, and it was okay. And then again, 3 months later, he came back to us with the same issue. Again, no flow, poor thrill, almost no thrill in his fistula. So same thing, we did the fistulogram, and you can see the lesion, and then no flow after that lesion. And actually his fistula was having some clots, so we injected this time some TPA, and we did the angioplasty. And again, you can see the waist, they're increasing in the cephalic arch compared to last time. So we did the balloon maceration using the 2-axis retrograde and antegrade venous access with multiple balloon dilatations. And this is the fistulogram, which is showing improvement in the flow with some residual clots. So we did some mechanical, just simple suction thrombectomy, and injected some TBA, and we used the bigger balloons for maceration, and the final result was acceptable. So again, we sent him for dialysis. He was okay, and same scenario, 3 months. So he is our customer every 3 months. So same thing. But this time he was okay. He was having some pulsatile thrill in his fistula with issues with the dialysis. So we did the fistulogram. The vein is growing up with the focal area of dilatation, but he had an issue with his cephalic arch, where we treated approximately twice before. So you can see the stenosis in the cephalic arch with the multiple collaterals. So we went to the balloon. You can see the waist clearly. So this time we decided, so after the fistulogram, there's still some residual stenosis, and he's been following with us and frequent customer with us for the last year. So this time we decided to go for stenting, and we chose the covered stent, the Viapan. So we did the angiogram, we positioned the stent, and it was deployed, and this is the final venogram, which is showing excellent flow with no collaterals. So he continued to do well, and he had good dialysis for a couple of months, and more recently he got transplant. So the cephalic arch stenosis is always an area of discussion, and during the last talks yesterday, there was a lot of discussions about the management strategies, and it's always variable, including conventional balloons, DCBs, cutting balloons, stenting, whether covered or bare metal, or even surgical options. And the literature, there used to be very variable data with non-satisfactory management strategies for the cephalic arch. There is this paper from Dr. Shemesh, who's one of the faculties of EVA meeting. This is one of the very early clinical trials comparing the use of angioplasty with bare metal stents versus covered stents, and they found good results with the covered stents in terms of the short-term restenosis and long-term patency. This is more recent systematic review and meta-analysis for the cephalic arch stenosis, and they were able to review around 125 studies, and some of them were randomized clinical trial. And again, the data now is more supporting the use of stent grafts with good results in terms of the primary and secondary patency. Again, this is one of the papers just comparing the stent placements after, with and without, with angioplasty, with and without stenting. And again, the data are more toward the use of stenting, especially for the recurrent stenosis. There's this paper which was published a couple of years ago on the specifically on the use of Viapan for a recurrent cephalic arch stenosis, which is basically similar to our case. And again, the data were very supportive, and it shows superiority for the Viapan graft compared to bare metal stenting or just PTA alone. So I think still there is a need for more studies and randomized clinical trials, though the data are very promising with the stenting. And thanks.